Inadequate safeguards for physician-assisted suicide. This discussion is going to argue that laws which currently allow physician-assisted suicide and laws which are proposed in various states, especially New York, which would propose to legalize physician-assisted suicide in the United States, do not include even minimal safeguards. For the moment, I'm going to assume, for the sake of argument, that physician-assisted suicide is not absolutely immoral, but that under certain circumstances, it might be moral. I will assume this for the sake of argument, even though I personally do not hold that view. But even if you do think that in some cases it may be a moral option, I would still argue that laws allowing it do not include enough safeguards to make it a moral option. In particular, I will argue that these laws do not include even minimal safeguards. Now, how would you define minimal safeguards? Well, I'm going to define it as safeguards which are proposed by the suicide advocates themselves. You would think that the laws proposed would meet the minimal standards which their advocates, at least in the medical field, are proposing. And these safeguards include a meaningful doctor-patient relationship, psychiatric consultation, palliative care consultation, and a waiting period. So number one, a meaningful doctor-patient relationship. Susan Block is a palliative care specialist and a person who would accept physician-assisted suicide in some cases, according to her published writings. She said that euthanasia and assisted suicide are inappropriate and dangerous outside the context of a meaningful doctor-patient relationship. The physician should have a broad appreciation of who the patient is in his or her life world, what the patient's values and beliefs are, and what kind of relationships impact on and will be affected by the patient's choice. Now, if you look at the doctor-patient relationship of assisted suicides in Oregon, we find that patients do not know their doctors well. 50% of patients knew their doctor for less than 3 months. About a quarter knew their doctor for less than 1 month. And at least one patient per year, maybe more, the data are not clear on that, but at least one per year knew the doctor for 1 week or less. And I would let you be the judge of whether that type of relationship is adequate for a choice of this magnitude. There's also evidence that patients in Oregon sometimes go doctor shopping in order to find someone who will do it. About a third had to ask more than one doctor before they found someone willing to do it. And if you look at prescribing patterns, it does seem as though there are certain activist doctors which are the go-to people to get this done. For example, in 2016, 102 doctors wrote 204 scripts, but the range was 1 script per doctor to 25 scripts per doctor, which means a single doctor wrote 12% of all the lethal scripts written in Oregon in that year. If you look at other data from previous years, 10 to 15 years old, we found that 10 out of 145 prescribers, 10 of them wrote 42% of all the scripts. So 10 out of 145 people who were willing to do it wrote almost half of all the scripts. And when you look at the proposed law in New York, there is no requirement for state residence, which means you might be getting people from Alabama or Texas coming to New York for their suicide pills. We would be a suicide destination, and you can think about whether that would promote a meaningful doctor-patient relationship. Dr. Timothy Quill and others said physician-assisted suicide should be carried out only in a context of a meaningful doctor-patient relationship, only to underscore that. Now, of course, I should be upfront. A suicide advocate may have a much more lax definition of a meaningful relationship compared to the rest of us. But, for example, these authors say that there may not always be a pre-existing relationship, which means this could be done on the first visit. But I would just let you be the judge of that, especially in a decision of this magnitude. The other thing I should say is I will be quoting these physicians, and I would encourage everybody to read them in context, because sometimes they do say things in a less strong way, but I think the quotes speak for themselves. And I think also, if you think about what a rational minimal safeguard should be, the quotes outline what most people would think. I think so. While I don't mean to misrepresent these authors, for example, Dr. Quill has gone on record recently saying the Oregon requirements are adequate, in his opinion, now, even though I will be quoting him from the 1990s, making various statements. So with that caveat, I will continue and let you be the judge. Psychiatric consultation is the second safeguard. Consider that people who are requesting suicide, they are requesting suicide possibly before they've had a chance to come to terms with their illness. So many people are shocked and in denial on the first day they receive their terminal diagnosis, and go through a process of trying to come to terms with that over the next weeks. But about half in Oregon, over a 10-year period, had less than 8 weeks from the date of diagnosis until their first request for a script, which means that they may not be completely coming to terms when they first request it. It is known that depression is common among terminally ill people who wish to hasten death, and there are numerous studies outlining that. And also there are studies which show that the treatment of depression, at least the successful treatment of depression, alleviates the wish to hasten death. So we can see why a psychiatric consultation might be important for a decision that is permanent. Now you might say, well, doctors diagnose depression all the time. Why would you need to involve a psychiatrist? And most of the literature focuses on ensuring whether the decision is voluntary, meaning whether there's a psychiatric illness that makes you incapable of making the decision. But I would like to focus on determining whether there's a treatable problem, whether depression or some other treatable problem is causing the desire to die. And this third point here is why expert consultation is helpful, because depression is difficult to diagnose in terminal illness due to symptom overlap. So here on the left column, I have the symptoms of depression. And of course, depression includes those. But if you look at terminal illness, that can also cause some of the same symptoms as depression. The illness itself can cause appetite changes. You may lose your appetite and lose weight. You may have trouble sleeping. You may feel things are hopeless because you have a terminal illness. Or you may feel worthless because you're disabled by the illness and can't do the things that you would like to do. There's grief involved with having any kind of bad news, let alone a terminal illness, and that can cause social withdrawal, or you might become irritable, sleep changes. Many of these symptoms are also symptoms of depression. And finally, side effects of medication can also cause some of the symptoms of depression, including depression itself. So depression is difficult to diagnose in this context, and it's helpful to have an expert consultation. Again, palliative care specialist Susan Block says patients should be seen by a psychiatrist. The differentiation of major depression from normal responses to serious illness is a highly specialized and difficult clinical task for which few non-psychiatric clinicians are adequately prepared. Participation in euthanasia or assisted suicide without such input is clinically unwise. And she even goes so far as to say that if your patient gets mad at you for suggesting that they see a psychiatrist, that you can simply present it as a routine step in responding to a request for accelerated death. So, in other words, she feels this should be done for everyone. Now, other suicide advocates may disagree, and in fact, others have gone on record saying psychiatric consultation is not needed in every case. But I would propose that it does make sense that a psychiatric consultation would be included in minimal safeguards, and that the fact that some people who advocate assisted suicide also believe that is telling. Psychiatrists themselves warn us that this is complicated in terms of determining voluntariness. Only 6% of psychiatrists in one survey were confident that in a single evaluation they could adequately assess whether a psychiatric disorder was impairing the judgment of a patient requesting assisted suicide. So on one hand, depression is a common problem that's treatable, and it's hard to diagnose in the terminally ill. On the other hand, laws allowing assisted suicide do not require psychiatric consultation. And in fact, in Oregon, people are not referred. Only less than 5% per year since about 2003 or so have been referred for psychiatric consultation. And in some years, nobody is. The third minimal safeguard is a palliative care consultation. Suicide advocates say that physician participation in any approach to terminal care that may hasten death may be a moral act only when comprehensive palliative care is unable to relieve suffering adequately. So this is a moral act only when palliative care fails. It's supposed to be a last resort. That's how it's billed to us in the literature. This is a last resort. And if I may infer, this would be an immoral act if palliative care is able to relieve suffering adequately. So why would an expert palliative care consultation be required? And that's kind of obvious because palliative care alleviates the symptoms causing the desire to die. But the other advantage of having an expert is that sometimes experience is required to determine if there is even a treatable cause of desire to die. Experience is required. And that it's hard to make a statement, it's hard to make that point quickly. And I'm going to have a whole separate segment on why experience is required to determine whether there's a treatable cause of suffering. Sometimes the patients don't even recognize it. These are very complex issues, and it can take a lot of time and effort and experience to get to the bottom of what's really causing the suffering. And sometimes that's a treatable thing. On the other hand, many of the doctors who are participating in physician-assisted suicide in Oregon are not experienced at exploring requests. And we know this because two-thirds of the people who wrote a script at all wrote only a single script over a 7-year period in Oregon. Now, you wouldn't trust a surgeon who was performing a complicated life and death surgical procedure who had only done it once in 7 years and had no certification to do so. It makes sense that if you're going to do this, if you're going to allow this, you should at least require a palliative care consultation. And in New York, there is no certification or training required at all. So if you want to prescribe narcotic pain medications, you have to do a 3-hour course every 3 years. If you want to prescribe medical marijuana, you have to do a 4-hour course. If you want to prescribe suicide drugs under the proposed law, there's absolutely no training required. No training for dosing, no training for how to administer the dose, for potential complications. Physicians don't have to receive training on that under the proposed law. That is a double standard. But what's even more important is there's no required training for determining the underlying cause of the wish to die. And again, I will have an additional segment devoted to that topic, why that would be important. But obviously, palliative care consultation can help alleviate the symptoms. So 46% of those in Oregon who were already requesting death changed their mind after a palliative care intervention. And in the Netherlands, it was reported to be 2/3. So this is almost a point that's doesn't need data to defend it. It's common sense. If you have palliative care, then you're going to have your suffering alleviated, and you will not have the desire to die anymore. Again, suicide advocates, Timothy Quill, but also others on this article, as part of their clinical criteria, proposed clinical criteria for allowing assisted suicide. So minimal safeguards. These are the medical criteria that the advocates themselves are proposing. Independent and impartial oversight by a certified palliative care consultant is a vital safeguard in this proposed policy of legalized physician-assisted death. Review by an independent palliative care consultant would be required whenever a patient and physician agreed to pursue this option. So this is a vital safeguard. And is this vital safeguard actually written into any of the laws in the United States which are currently enacted? And is it written into the proposed New York State legislation? And the answer to that is no. The legislation does not meet the minimal safeguards recommended and required by the suicide advocates themselves. This seems like a bait and switch. On one hand, the rhetoric is saying palliative care consult is a vital safeguard, it's an immoral option without palliative care, and suicide should be a so-called last resort that indicates a failure of modern medicine. On the other hand, the proposed laws and actual laws in other states do not require a palliative care consult. They do not even require the patient to be suffering. In order to get suicide drugs under any law in the United States, you don't have to be suffering. You merely have to have a terminal illness with a 6-month prognosis. And it does not require any training of physicians in how to explore requests for death. So this seems like a bait and switch. On one hand, we're talking about people who are suffering, who suffering can't be relieved by palliative care, and then when the laws actually get enacted, it has nothing to do with suffering. You don't even have to be suffering. The fourth minimal safeguard is a waiting period. Now, this is not actually explicitly demanded by suicide advocates in their proposed criteria, but their clinical criteria do require that the desire to die be persistent, pervasive, and strong. And the only way you're going to know that is if you have a waiting period. And in fact, for most people, the desire to die is transient and weak, and they are ambivalent. 50% of those who were seriously considering suicide with a terminal illness changed their mind within 2 to 6 months in one study. On the other hand, within that same time period of about 2 months, you have 50% of those in Oregon who just received their diagnosis asking for a script. In Oregon, there's a 15-day waiting period. The proposed New York law has no waiting period. So in summary, the proposed law in New York and laws in other states in the United States do not provide even the minimal safeguards proposed by the suicide advocates themselves. These laws and proposed bills have no requirement for suffering. There's no requirement that you have attempted or received a palliative care consultation. There's no requirement for a psychiatric consultation. There's no requirement for a meaningful doctor-patient relationship in the sense that most of us would think of it. There's not even a requirement for state residence in the proposed New York law. And there's no requirement that the request be persistent, as manifested by a waiting period. And there's no required training for prescribers who would be prescribing suicide pills. So for all these reasons, I think even if you believe that physician-assisted suicide may be a moral option in certain circumstances, we should still be opposed to the proposed law in New York and the laws currently enacted in various jurisdictions in the United States.